Seminoma stage 1 workup, H&P, do a assessment of a painless testicular mass, history of undescended testicle and genetic syndromes or birth defects, sexual history, history of testicular trauma. Ask about history of prior ipsilateral surgery, horseshoe kidney, inflammatory bowel disease. Imaging, get an ultrasound of bilateral testicles, which would show a homogeneous hypoechoic mass, which is generally pathognomonic for a seminoma. Fertility banking, sperm count and sperm banking, labs, get a beta HCG, AFP, and LDH. Repeat again after surgery. TNM staging is based on post-surgery labs. Surgery is a radical inguinal orchiectomy with high ligation of the spermatic cord. Treatment, preferred treatment, observation, salvage rate is 95%. Radiation or chemo are also options, especially if the patient is expected to have poor compliance with follow-up, but may use classic dogleg field in situation of expected poor follow-up. The radiation treatment is 20 gray in 10 fractions. Another option is chemotherapy with carbo AUC 7 times 1 cycle. SIM, first assess fertility and offer sparing. Supine clamshell, position the penis out of field. Dose is 20 gray in 10 fractions. Borders, T11 to T12 down to L5 to S1, i.e. T12 to L5, laterally out to the transverse processes 10 centimeters wide, or if you're contouring vessels, add 1.9 centimeters from the aorta and 1.2 centimeters from the IVC per Wilder review. Do not widen the field laterally to cover the left hilar nodes, the left gonadal vein. If left-sided primary, this is an old practice. 2D fields and 3D atlas, Wilder et al. Chemo, another treatment option, is carbo AUC 7 times 1 cycle. The adverse events there are renal toxicity, ototoxicity, hair loss, and myelosuppression. Follow-up, surveillance, H&P every 3 to 6 months for the first year, and then every 12 months. Per NCCN, serum markers are optional and only recommended for bulky disease. CT every 3 months for the first year, then yearly. After treatment of stage 1, follow-up annually with annual CT. For stage 2A to 2B, follow-up every 3 months for the first year, then every 6 months, baseline CT, and then annually, chest x-ray every 6 months for the first 2 years. Treat recurrences with BEP chemo if not given prior, second-line chemo as below. Outcomes, 10-year relapse-free survival is 98%. Observation relapse rate is 10 to 20%. Observation salvage rate is 95%. 3-year disease-free survival is 98% for chemo and 88% for surveillance. Secondary malignancy is a relative risk of 2. Adverse events are nausea, vomiting, and infertility. Additionally, seminoma, stage 2A is a node less than 2 centimeters. Stage 2B is a node size 2 to 5 centimeters. Stage 2C and 1S get BEP times 3. For stage 2A, radiation is preferred. For stage 2B, chemo with EP times 4 cycles is preferred per NCCN. Radiation is also an option. Stage 2C, BEP chemo, no radiation. This would be 20 gray in 10 fractions plus a 10 gray boost to 2A nodes or 16 gray boost to 2B nodes. Radiation is preferred for stage 2A. For stage 2B, BEP times 3 to 4 is preferred, but radiation is also an option in select non-bulky patients. See above for SIM. Dose, again, is 20 gray in 10 fractions. Boost is 10 gray for 2A or 16 gray for 2B. The modified dogleg field is T11 to T12 down to the top of the acetabulum with 2 centimeter boost on gross nodal disease. At L5 or S1, you should curve the dogleg. The new medial border should be the medial obturator foramen. The new lateral border is the acetabulum. Maintain a 10 to 12 centimeter width, if not contouring. Contouring would be contour the vascular structures with a 1.9 centimeter border on the aorta and a 1.2 centimeter border on the IVC with 1.2 centimeters on the iliac vessels. Do not widen to include left renal hilum. There's no chemo with radiation. EP times 4 cycles if you're not doing radiation, which is etoposide 100 milligrams per meter squared and cisplatin 20 milligrams per meter squared on days 1 to 5 every 3 weeks. Dosimetry, be aware that sterilization at 2 gray to the testicle. Transient azospermia is 50 centigrade, 50% recover. Clamshell reduces the dose 2 to 3 times. Dogleg 2% to 1% or 4 centigrade per fraction to 1.5 centigrade per fraction. For a PA field, have the numbers above. D, 50% to each kidney should be less than 8 gray. Mean dose to both kidneys should be less than 9 gray. For a boost, each kidney D50% should be less than 2 gray. For a solitary kidney, D15% is less than 20 gray. There's no role for radiation for non-germinomatous germ cell tumor. Follow-up again for stage 2A to 3 CT after treatment. If there's residual mass less than 3 centimeters, then observe. If it's greater than 3 centimeters in size, then do PET. If it's negative, observe. If it's positive, do retroperitoneal lymph node dissection versus second-line chemo. If you have bulky disease, then follow up with markers every 2 months for the first year, every 3 months for the second year, every 6 months thereafter. Get a CT every 6 months, chest X-ray with follow-up for first 2 years and annually. 10-year relapse-free survival, 92% for stage 2A, 86% for stage 2B, 70% for stage 2C. Overall survival for stage 3 is 90%, 30% can have children. For seminoma with prior surgery, including stage 1 to 2, treatment here would be 20 gray and 10 fractions, boost 10 gray for 2A, boost 16 gray for 2B. Classic dogleg field, use classic for prior surgery if the patient desires treatment but may have poor follow-up after treatment. Again, superior borders T10 or T11. Inferior is mid-obturator foramen, include the ipsilateral renal hilum vertically down to L5 to S1, then diagonal to the lateral edge of the acetabulum, then vertically down to the lateral mid-obturator foramen, keep 10 centimeters wide. On the opposite side, after the diagonal, the new alignment is the medial obturator foramen down to the mid-obturator foramen. For seminoma, stage 2B through 3C, do BEP chemo. In stage 2B, chemo is preferred, but radiation is also an option. For stage 2A to 3, do CT after treatment. If the residual mass is less than 3 centimeters, then observe. If it's greater than 3 centimeters, then do PET. If negative, observe. If positive, treat with either retroperitoneal lymph node dissection or second-line chemo. For seminoma recurrence after surveillance, salvage rate is 95%. Consider offering radiation for isolated inguinal, pelvic, or PA recurrence. Per NCCN, chemo is recommended, and there is no indication for radiation recurrence, but it seems reasonable to consider radiation for localized regional recurrence. Chemo options BEP. If they've been given prior chemo, give VEIP or TIP. Give BEP if recurrence after OBS. If given prior chemo, VEIP is vinblastine, mesna, ifosfamide, and cisplatin. TIP for Tipper-Gore's, paclitaxel, ifosfamide, mesna, and cisplatin. Bladder preservation, T2 to T4A. T4A is allowed per NCCN. No hydronephrosis, but may be acceptable if resolved. No extensive CIS. Must have maximal TURBT. Workup for bladder preservation, H&P. Assess for hematuria, urinary irrigation, fever, back pain, travel history to Egypt, dye or toxin exposure, obstructive symptoms, smoking history, or past chemotherapy. Labs get a UA, urine cytology, CBC, and ALK Phos. Do cystoscopy with maximal TURBT and tumor mapping. Imaging of the upper tract, CT without contrast with retrograde pyelogram, CT urography, renal ultrasound, MRI urogram. Imaging should be CT abdomen pelvis and MRI. Staging, bone scan of ALK Phos elevator, bone pain, chest X-ray or chest CT. Traditional regimen, 39.6 gray to mini pelvis fields with empty bladder. Check response on cone beam CT through treatment. Then boost bladder to 54 gray. Boost tumor volume to 64.8 gray with full or empty bladder. Consider boosting higher for gross disease. Do not insert a break in radiation while checking response, as was done in older trials. Breaks are not beneficial radiobiologically. Many variations exist. Mini pelvis is common. Whole pelvic RT dose may lead to too much dose of the small bowel. Some omit elective nodes, BC 2001. Consider whole pelvic RT for T3. Inclusion of common iliacs for node positive or T4. Note that the bladder can be treated to 45 to 54 gray with a boost to 60 to 70 gray, higher for gross disease. IMRT SIB can be done similar to head and neck, such as 66 gray, 56 SIB. Bowel anatomy may determine whether full or empty bladder is ideal. Sim should be supine backlock. Empty bladder is more reproducible. Some boost with a full bladder. Dose, traditional mini pelvis 39.6 gray, bladder 54, GTV boost 64.8. Variation, mini pelvis 45 with a boost 60 to 70. IMRT SIB 33, mini pelvis 56, GTV 64.8 to 70 gray. Contouring IMRT variations in practice. 1 is whole bladder with boost to GTV. 2 is IMRT SIB boost. 3, treat only GTV. IMRT may be used to protect the bowel. Some portions of the PTV may need to be undercovered. With cone beam CT, use PTV such as 1.5 soup ant and 1 centimeter in the other directions. Bladders with large tumors are often not flexible and can tolerate smaller margins. Variations in extent of the nodes included: 1, no nodes; 2, mini pelvis plus or minus sacral nodes; 3, whole pelvis, possibly for higher stages such as T3, T4 node positive. 3D mini pelvis field, superior border would be mid SI, inferior would be bottom of the obturator foramen, lateral 2 centimeters on the pelvic brim, anterior 2.5 centimeters anterior to the bladder boundary, posterior 2.5 centimeters beyond the bladder and mass. Block femoral heads, bowel rectum, bladder boost 2.5 centimeter PTV around the bladder, tumor boost, use pre-CT cystomapping to delineate. Chemo category 1, cisplatin, 5FU or 5FU mitomycin C. Category 2B would be carbotaxol or low dose gemcitabine. What do you do if the patient has hydronephrosis? Place nephrostomy tube, and if hydronephrosis resolved, consider bladder preservation. There are no differences in response with hydronephrosis. Bladder preservation is a category 1 in NCCN even for node-positive disease. Cystoscopy every 3 to 6 months for 2 years, then increasing intervals with regular imaging and lab evaluation. Check vitamin B12 if ileal conduit is constricted. Outcomes RTOG meta-analysis, path CR rate is 69%, complete response rates 74% in T2, 67% in T3 to T4A, 73% in complete TURBT, 56% in incomplete TURBT. 5-year intact bladder is 80%, 5-year overall survival 57%, 10-year overall survival 36%, 5-year disease-specific survival 71%, 10-year disease-specific survival 65%, muscle invasive local failure at 5 years is 13%, 10 years is 14%, non-muscle invasive local failure at 5 years is 31%, 10 years 36%, 5-year distant Mets is 31%, 10-year distant Mets is 35%, acute bladder irritation, dysuria, increased frequency, diarrhea, late radiation cystitis, hematuria, bladder fibrosis, urethral stricture, GI toxicity, and erectile dysfunction. Bladder preservation, hypofrac, indications, those with time constraints or performance status issues who may not be able to complete the long course of RT. Hypofrac would be 55 gray to the tumor with an SIB of 44 gray to the bladder and 20 fractions. Nodes not included. Treat throughout on an empty bladder. Supine Vaclock, empty bladder more reproducible. IMRT, SIB 20 fractions, bladder 44 gray, tumor 55. Hypofractionation, use cone beam CT with PTV such as 1.5 centimeter soup ant and 1 centimeter in other directions. Chemo, again, is cisplatin 5FU or 5FU mitomycin C with carbotaxol and low dose gems, category 2B. Hypofrac, small dose. Small bowel, no dose constraints were outlined in BC 2001. Low toxicity in BC 2001 suggests max less than 58 gray may be appropriate. A max of less than 53 gray is equivalent to a max of less than 54 small bowel if using BED. Note that in BC 2001, hypofrac was not found to be non-inferior but did have favorable outcomes. The BC 2001 BCON meta-analysis did show non-inferiority, but the original arms were never randomized. Thus, the level of evidence is similar to a propensity analysis. For bladder T4B or node positive, treatment is similar to bladder preservation. Chemo RT or chemo alone is also an option. You want to reassess at some point. If there's no tumor, proceed to cystectomy or give further radiation. I would treat pelvis with whole pelvic RT and consider inclusion of common iliac nodes. Bladder rare histology, squamous cell, treat with local therapy, surgery, or radiation. There's no role for chemo. There's a mixed histology. If urothelial is still present, treat as normal bladder cancer. Adenocarcinoma, no role for chemo, treat with surgery or RT. With surgery, sacroiliac ligament and umbilicus. Small cell would treat with neoadjuvant cisplatin and etoposide, then local treatment. Sarcoma, bladder, treat per sarcoma. Bladder cystectomy, adjuvant radiation. Indications consider for PT3 to T4. Positive nodes, positive margins are high grade. Evidence here is phase 2. I would treat 45 to 50.4 plus boost to areas of positive margin or gross disease. Typically give neoadjuvant chemo. If not given, consider adjuvant chemo for PT3, T4 positive nodes. Again, the dose is 45 to 50.4 gray plus boost to areas of positive margin, extranodal extension, or gross disease. Typically give neoadjuvant chemo. If not given, consider adjuvant chemo for PT3 to T4 positive nodes. Field negative margins would be pelvis, including the distal common iliac, internal iliac, external iliac, obturator. No presacral nose or cystectomy bed. Positive margins, pelvis as above, and also presacral nose in the cystectomy bed. Cystectomy bed, superior is 2 centimeters above the pubic symphysis, anterior is the pubic symphysis, posterior is the anterior third circumference of the rectum. Above the rectum, extend the plane of the anterior rectum upwards. Lateral would be the obturator internus, the vaginal wall, and the prostate bed. Inferior would be 2 to 3 millimeters above the penile bulb and 1 centimeter below the lower obturator foramen for females. No beams through the ostomy bag. Chemo dose would be DD-MVAC times 4. MVAC is methotrexate, vinblastine, doxorubicin, cisplatin with growth factors, or Gem-Cis, or CMV, cis, methotrexate, vinblastine. Ostomy bag, no beams through the ostomy bag. Urinary diversion, contour as an avoidance structure. For recurrent bladder cancer, radical cystectomy if they're a surgical candidate. Give gemcitabine, carboplatin if cisplatin was already given. If they can have cisplatin, give cisplatin gemcitabine. Prostatic urethra, there's no indications for radiation per NCCN. Prostatic urethra cancers, stromal invasion, you need cystoprostatectomy plus or minus urethrectomy. For prostatic urethra with just ductal acini invasion, you might be able to do TURP plus BCG. You can use adjuvant chemotherapy for T3, T4, or node-positive disease, or neoadjuvant chemo if factors are already present. For urethral cancer, workup would be cystoscopy with EUA and TUR, imaging of upper tracts, PSA, DRE, and an MRI. Urethra, you always want to biopsy suspicious nodes. This could be infection. Surgery, again, would be urethrectomy with cystoprostatectomy. Any T1 tumor or less should be a transurethral resection followed by BCG. For a T3 or T4 and node-positive tumor, consider neoadjuvant chemoradiation followed by surgery versus just chemoradiation alone. Prostatic urethra T2, for stromal invasion, you need a cystoprostatectomy plus or minus a urethrectomy. For a prostatic urethra or just ductal acini invasion, you might be able to do a TURP plus BCG. For a male pendulous or bulbar urethra that's T2, do a partial penectomy or a distal urethrectomy in select cases. For bulbar urethra, you need urethrectomy plus or minus cystoprostatectomy. For a postoperative positive margin, attempt to re-resect or give chemoradiation. For a post-op PT3 or T4 or node-positive, give chemo or chemoradiation. For a female urethra T2, chemoradiation or urethrectomy plus or minus cystectomy. Next is penile conservation, workup, sexual risk factors, imaging not required if there are no palpable lymph nodes. Biopsy can be a punch biopsy, an excisional biopsy, or an incisional biopsy. You want to do a dynamic sentinel lymph node biopsy for low-risk TIS, TA, and T1A. Do a dynamic sentinel lymph node biopsy or inguinal dissection for T1B or greater. Biopsy suspicious inguinal nodes. They could be reactive. Penile conservation or penectomy. NCCN brachytherapy guidelines include T1 to T2 N0 tumors with size less than 4 centimeters in any grade. In terms of treatment, perform a circumcision if it's not already done. 3840 centigrade and 12 fractions, 320 centigrade per fraction is the European guidelines, or 36 gray and 9 fractions, the first fraction at 6 gray and subsequent fractions at 375 centigrade BID. Radiation. I would place the patient under anesthesia with preoperative antibiotics. I would sterilize and drape the patient and place a Foley catheter. I would insert interstitial needles such that the CTV is covered in a parallel fashion, avoiding penetration of the urethra and dorsal vein. After placement, I would examine the urethra for blood and mobility. You want to treat 60 to 65 gray, iridium 192 interstitial, limit urethra to 60 gray versus EBRT 40 gray to the shaft in a box. Bolus plus 20 gray boost with 2 centimeter margins. NCCN says 65 to 70 gray with chemo. SIM may bolus areas under the surface with lubricant and wet gauze. Chemo would be cisplatin. Dosimetry for the 3840 centigrade regimen, the target V125 is less than 40%, V150 less than 20%, urethra, V115 less than 10%, V90 less than 95%. For the 3600 centigrade regimen, target V100 greater than 95%, V150 greater than 35%. Avoid confluence of two 200% isodose lines and avoid a 200% isodose of greater than 1 centimeter. Urethra V115 less than 1%. Penile preservation is feasible in 75% with a local failure of 15 to 30%. Necrosis is seen in 20 to 40% and stenosis of the urethra in 10 to 40%. Non-seminomatous germ cell tumor. For stage 1A, you want to do observation or retroperitoneal lymph node dissection, after which, if they're PN1, you want to observe or do BEP times 2. If they're PN2, you do BEP times 2. If they're PN3, you do BEP times 3. For stage 1B, you do OBS or BEP times 2 or retroperitoneal lymph node dissection. For stage 2A, do chemo or retroperitoneal lymph node dissection. Assuming all post-op markers are within normal limits is what you do as above. For stage 1S, 2B to 2C S1, 3A BEP times 3. For stage 3B, 3C BEP times 4. Again, chemo is BEP times 2 to 4 depending on the stage. If you're doing OBS for stage 1, 30% will relapse, and nearly all within year 1. In spite of this, salvage chemo is 98% effective. If you have residual tumor 1 centimeter or less, observe. If residual tumor is greater than 1 cm, do surgery or retroperitoneal lymph node dissection specifically. Worst prognosis, MS site, visceral non-pulmonary mets, elevated markers. Good equals no mets or pulm mets, testicular or retroperitoneal site, beta HCG less than 5,000, AFP less than 1,000, and LDH less than 1.5 equals a 5-year overall survival of 92% and 5-year progression-free survival of 89%. Ureter treatment. Radiation is generally not employed, but might be considered for positive margins or unresectable lesions. If operable and using radiation, consider 45 to 50.4 gray. Then boost to 54 to 70 gray total as feasible per bowel tolerance. See the field section. The field cover renal fossa and peri-aortic lymph nodes from superior L1 to the aortic bifurcation. The publication of Gao found that recurrence at the ureteral stump should be low with modern surgery and did not recommend coverage of this region. Covering the ureter stump or ureter length is an option based on risk factors. Lastly, kidney radiation for palliation, SBRT for inoperable patients. NCCN radiation gives no benefit even if node positive or positive margin. After surgery, follow-up only. Sunitinib or pazopanib only in the event of relapse. Lastly, gynecomastia occurs with patients on bicalutamide. Monotherapy, gynecomastia occurs in 90%. First line is tamoxifen, which is more effective than radiation. Radiation is 12 gray in 4 gray per fraction at 3 fractions, or 10 gray, 12 gray, 15 gray single dose. Radiation can be used for prevention or also treatment of gynecomastia or breast pain. Again, 12 gray in 3 fractions or 10 to 15 gray in 1 fraction. You want to do en-face electrons to 85 to 90% isodose line with a 10 centimeter diameter bolus, 10 centimeter diameter block over the nipple can be used. No bolus, skin is not a target. Tamoxifen can be used as an alternative, which is more effective in preventing gynecomastia and breast pain.